Welcome to your next major organ system. When reviewing for the NCLEX 1 exam, we're going to enter into the gastrointestinal system. And in this, we're going to focus on some high yield material that can apply to NCLEX 1. It also can apply to USMLE Step 1 or COMLEX, but we're really focusing on NCLEX 1. So remember, NCLEX 1 is not a diagnostics exam, it's a pathophysiologic exam. So we'll lean into physiology, pathology, and some microbiology in this next lecture. First, focusing on the physiology, we're going to dig into our histology of the gut, looking first at the layers of the GI wall and also leaning into some high yield topics of the enteric nervous system. So our GI wall layers, we start with this kind of common layering system that we can see in all of our hollow organs. Our mucosa layer is going to be the closest to the lumen, then submucosa, muscularis propria, and then the serosa or adventitia. So our mucosa layer, that is epithelium with lamina propria and muscularis mucosa. Our submucosal layer is where we have our Meissner's plexus. This is what controls secretion and absorption. Again, board pearl is making that connection. The muscularis propria is kind of the inner circular and outer longitudinal muscle layers, smooth muscle that move things along. And the outermost layers where we have our arbox or myenteric plexus. This is the muscular layer that controls motility. It's important to be able to connect these pieces pathologically. So in Hirschsprung's disease, we have an absence of the R blocks or the myenteric plexus or ganglia. So there's a functional obstruction that can occur in the gut. And again, our enteric nervous system is that GI-based nervous system that contains over 100 million neurons, and it's independently operating from the CNS, central nervous system. Sometimes it's called the second brain because this controls peristalsis, secretion, and blood flow. Autonomically, it has input parasympathetically, which increases motility, and our sympathetic nervous system, which decreases motility. Some motility types in the gut include peristalsis. This is the progressive contraction that occurs behind a bolus of food, and then there's relaxation that's occurring ahead of food. We see this in places like the esophagus, specifically in small intestine, as well as colon. It's coordinated by our enteric nervous system. This is not a voluntary process. And it can be damaged in the esophagus in conditions like achalasia, where the lower esophageal sphincter fails to relax. Segmentation is a non-propulsive contraction. It's really meant to mix chyme. We see this primarily in our small intestine after eating, and you'll see the ability to increase the contact of chyme with brush border enzymes, but it's not actually moving content forward as it is in peristalsis. The migrating motor complex is our housekeeper. It provides contractions to our small intestine during fasting or a large intestine. Every 90 minutes about, we'll see this kind of phase 3 sweeps debris distally towards the end of our colon, and it's initiated by motilin, a hormone. In certain conditions, like in small intestinal bacterial overgrowth, this motor complex can become disrupted and we have slow motility. And then our mass movements are really powerful peristaltic sweeps that occur in the colon. It's triggered after eating by our gastrocolic reflex, gastrostomach, colic, colon. And there can be about 3 to 4 per day that really push feces towards the rectum. And it's the kind of urge to defecate that can occur after meals. Looking at our gastric secretions, it's important to be able to match the cell type, the location, the products of the cell, what they're stimulated by, and what they're inhibited by. For instance, our parietal cell is located in the fundus slash body of the stomach. It secretes hydrochloric acid and intrinsic factor. Acetylcholine, gastrin, and histamine increase that. Somatostatin, prostaglandin, secretin, and PPI medications will inhibit it. Chief cells, same location, secrete pepsinogen and gastric lipase, stimulated again by acetylcholine, but also secretin and low pH. Our G cells are in the antrum of the stomach and secrete gastrin, and they're stimulated when there's lots of proteins around, so amino acids, also acetylcholine, and an elevated pH. It's inhibited when pH is low via negative feedback and somatostatin, because gastrin, again, is going to stimulate the release of hydrochloric acid. D cells is located in the antrum and then also the pancreas, secreting somatostatin, which is stimulated by lower pH or fat or cholecystokinin. It's inhibited by acetylcholine, which is the master, and somatostatin itself is the master inhibitor of all GI secretions. So it's important to kind of keep that in mind. Our ECL cells, our enterochromaffin-like cells, is from the fundus in the body, like parietal and chief. This secretes histamine, which is going to be stimulated by gastrin to encourage hydrochloric acid secretion, and it's inhibited by some medications, a histamine blocker. And then our mucus and neck cells are throughout, and they secrete either mucus or bicarb. They're stimulated by acetylcholine and prostaglandins, and they can be inhibited by NSAIDs. Parietal cells of note make both hydrochloric acid an intrinsic factor, and if you lose them, such as in an autoimmune condition called pernicious anemia, you are unable to absorb B12 via the terminal ileum. You can then see a megaloblastic anemia and combined degeneration that's subacute of the dorsal columns and the lateral components of the corticospinal tract in the nervous system. So you have issues with or nerve transmission. There are three physiologic phases of gastric secretion that you need to understand, starting with the cephalic phase. This is where the sight and the sound and the thought of food is going to lead to cranial nerve 10 or the vagus nerve being stimulated, releasing acetylcholine, which will lead to an increase in hydrochloric acid, pepsinogen, and gastrin, encouraging the preparation of the stomach to receive food. Our gastric phase starts when food enters the stomach via gastric distension. The G cells release gastrin, which increases hydrochloric acid secretion by parietal cells, and also intrinsic factor is secreted as well. And then the intestinal phase starts once the chyme from the stomach enters into the duodenum. Cholecystokinin from eye cells, or cholecystokinin due to fat and proteins act on eye cells, and secretin from acids acting on S cells will lead to decreased gastric emptying and decreased acid secretion, essentially shutting down these phases. When we think about digestion of our macro and micromolecules, carbohydrates, we have start to have their breakdown via of starch via salivary amylase and pancreatic amylase into oligosaccharides, which then are broken down by brush border enzymes, maltase, sucrase, and lactase into monosaccharides. Glucose and galactose are taken up into cells via the SGLT1, which is a sodium-dependent receptor. And fructose is taken in through cells via the GLUT5 receptor. And glucose and fructose exit the enterocytes via a GLUT2 transporter. Proteins start their breakdown in the stomach via pepsin and a low pH into polypeptides. Then trypsin, chymotrypsin, and elastase, which are pancreatic enzymes activated by enterokinase, are going to break the proteins down into dipeptides and amino acids, which then move via sodium-coupled transporters into the enterocyte. Enterokinase activates trypsinogen to trypsin, and trypsin activates all other zymogens or inactive enzymes. And then our fats, our triglycerides are broken down via pancreatic lipase and colipase, which it needs bile salts to do to free fatty acids. That's then taken up into the cell via micelles, via passive diffusion. They are then re-esterified back to triglycerides and packaged into chylomicrons, which are taken up into the lacteals, which then eventually make their way into the lymph. Our bile salts are recycled via our enterohepatic circulation in the terminal ileum. Some important nutrients to note where they're absorbed and what can affect them is iron. This is absorbed in the duodenum primarily. Vitamin C encourages absorption via the DMT1 transporter, and it needs an acidic environment. Calcium is absorbed in the duodenum and jejunum. It's absorbed via active transport and requires calcitriol or vitamin D3. Folate is absorbed in the jejunum. This is in its reduced form, tetrahydrofolate. When there's a deficiency, it can lead to megaloblastic anemia. Vitamin B12 is only in the terminal ileum along with bile salts. And vitamin B12 requires intrinsic factor to be able to be absorbed. Intrinsic factor is made by our parietal cells in our stomach. And then bile salts is our enterohepatic circulation. If you had potential resection or removal of the terminal ileum, you could see fat malabsorption and potentially diarrhea. And then our fat-soluble vitamins are reabsorbed in the small intestine, and it requires micelles. And so patients who are deficient in fat malabsorption, cholestasis, or cystic fibrosis can lead to a deficiency of fat-soluble vitamins. When looking at our gut hormones, we can again look at the name, their source, their stimulus, and their key actions. So, gastrin comes from G cells in the antrum of the stomach, and it's going to be stimulated by proteins or high amino acid concentration, acetylcholine, and increased pH. It's going to increase hydrochloric acid and intrinsic factor. It'll also increase gastric motility and it'll increase mucosal growth. You can have excess gastrin in a condition called Zollinger-Ellison syndrome. Secretion is secreted by the S cells in the duodenum, and its stimulus is when there's acid in the duodenum or low pH in the duodenum. Increased bicarb is from pancreas and bile is going to be a trigger from our secretin, therefore decreased acid. And secretin stimulation is a test that can happen for Zollinger-Ellison syndrome. Cholecystic kinin secreted in the duodenum as well, the small intestine and the eye cells, and it's going to be stimulated by fat and protein in the duodenum. We'll see pancreatic enzymes, increased gallbladder contraction, and decreased gastric emptying with increased satiety. GIP is going to be our glucose insulin peptide, and we'll see that being secreted from our K cells or our duodenum in our duodenum. Its stimulus is our macromolecules, and it'll have an incretin effect. It'll increase insulin, it'll decrease gastric acid, and it is glucose dependent. Motilin is from our M cells in the small intestine. This is secreted in response to fasting or an alkaline pH. And it's going to initiate our migrating motor complex, phase 3, which is our digestive housekeeper, as we've learned. Our VIP, our vasopeptide, is going to be coming from our enteric nervous system, and its stimulus is fat or acetylcholine. It's going to increase intestinal secretion, increase smooth muscle relaxation, decrease gastric acid, and in a VIPoma, you can see watery diarrhea. Somatostatin secreted by our D cells in our pancreas and our gastro or our stomach. It's also stimulated by our macromolecules and it inhibits all GI hormones. It's also going to decrease insulin and glucagon, and there is a synthetic analog. And lastly, ghrelin is created in the stomach, and its response is fasting or hunger. It's going to increase appetite, increase our gastrin hormone release. It's going to be higher before meals, and it's going to be lower after eating.